Silajit, can we start?
Yes, sir. So you can start now, sir.
Yeah, I hope I am audible and visible, isn't it?
Yes, sir.
Yes, sir.
Okay. Now, when we talk about imaging in breast surgery, I am going to take you through two certain areas. Number one, we are going to talk about the basics of ultrasound, the basics of mammogram, and the new kid in the block called elastography. We are going to talk about MR and then the interventions that are necessary in today's world. Now, we are going to brush our knowledge right at the beginning by telling the features in mammogram are a mass with associated calcification, with architectural distortion, with asymmetry of architecture, with asymmetry of tissue density, and I'm going to show each of them separately how it works, and skin and nipple changes. And these are the different views that we use in mammogram. Most of us will be happy to do a craniocaudal and a mediolateral oblique view. And depending on the location, we might have to use the other things. And it can be straight mediolateral or lateromedial, the spot view, the double spot compression view. You need not know about all of them. What you need to know that the standard is the craniocaudal and the mediolateral. And at times, they remain in such an extreme medial or an extreme lateral position, or the microcalcification is so small. I'm going to show a few pictures where you need a compression view to understand where exactly it is situated. But by and large, it is 2 or 3 view with the variations depending on the scenario. So these are the features, and based on which the BIRAD is set. Now, when you have a lesion which is absolutely smooth like this, be it in ultrasound, be it in mammogram, there is whatsoever no doubt that this is a clear-cut benign lesion. The confusion starts coming when we have an obscuring thing coming out of one edge. The confusion is compounded when we have microlobulations. When one side looks like a tail of some sort of star, the other side is smooth, then again comes confusion. And finally, if you have a speculation like this, there is no confusion. So as you understand, the one above and the one below, both are without any confusion, but anything in between will have a subjective element in diagnosis. And therefore, as I said, the new kit called the elastography might resolve these confusions which are found in lesions in between. We come to the stepson. Now, this stepson, actually, I don't know why this has been kept in abeyance for long. But if you try to look at this, again, the features are speculation. If you have angular margin, you have microlobulation, you have a lesion which is taller than it is wide, you have ductal extension, you have acoustic shadow, calcification, and hyperechogenicity and hypoechogenicity in combination, you think it is in ultrasound, it is a malignant lesion. You can add a Doppler to it. And if you add a Doppler and you find that there is a huge gush of blood going into the diastolic phase of the lesion, you think it is either a malignant lesion or it can be an inflammatory lesion as well. Second is in Doppler, if you find that the vascular pattern is completely random, that also is going to give you an information that possibly you are dealing with a malignant lesion. Now, before we go into the details of each of them, as a baseline, look at these two lesions. Now, if there is somebody in the group who can tell me what this lesion can be, is it benign or it's a malignant lesion? This lesion, anybody in the group?
Benign, sir.
And why do you think it's benign?
Smooth surface.
Why do you think it's benign?
Wider than tall.
Wider than tall, wider than tall.
There is regular margins.
Homogenic.
So
Clear.
as a, yes. So, very good. So, and why do you think it is malignant?
taller than wide.
Then now, so all of us agree that this is a benign lesion. And why it is benign? Number one, it is, look at this, this is wider lesion. Number two, it is a well-capsulated lesion. There is absolutely no heterogeneity, no hypoechoic or hyperechoic element in this. And there is no acoustic shadow. But look at this. There is a distinct acoustic shadow in this. So a lesion which is taller, a lesion which is irregular, a lesion which should have a perilesional halo like this is missing here with an acoustic shadow is a clear-cut malignant lesion. So the points to remember once again is a taller lesion, a lesion with perilesional halo, a lesion with architectural distortion, and with a posterior acoustic shadow is likely to be a malignant lesion. Now, this is the famous BI-RAD classification. I'm sure all of you know, and it is customary for me to narrate that 0 is incomplete, 1 is negative, 2 is a benign, distinct benign lesion, 3 is a probably benign lesion, 4 is a suspicious lesion, and again it can be 4A, 4B, or 4C. 4A means low suspicion of malignancy between 2 to less than 10%. B is moderate suspicion, more than 10 to less than 50, and high suspicion is more than 50 but less than 95%. 5 is highly suspicious of malignancy, more than 95% likelihood, and 6 is a non-biopsy proven case of malignancy. So as you see in 3, 4, there is always a possibility to go to either way, and therefore the role of newer tools have come very strongly in 3 and 4. Now let us start with the benign lesions and its variants. Now, as we have already discussed, this is a clear-cut benign lesion because of the blah, 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 blah factors that we have seen. Now look at this lesion. Again, in mammogram, this is a distinctly benign lesion. And you are going to say, see, the margins are very smooth, and therefore this is a benign lesion. Now, what is the difference between the two? Now, both of them look benign. Now, this is a benign for sure. Now I give you the third picture. Now look at this picture. This is also a benign lesion because there is a perilesional halo. The transverse diameter is more than the anteroposterior diameter. But what is the difference in between the picture in this one and this one? Mammographically, both will look the same. The important feature is the clefts in between. Now, if in a lesion you find intralesional cleft that you find here, that is not a fibroadenoma but a phylloid tumor. So the hallmark of a phylloid tumor is it looks like a fibroadenoma by and large. In mammography, it's almost like a giant fibroadenoma, but in ultrasound, you are going to get intralesional clefts, and that is the hallmark of a phylloid tumor. Now this is once again the same picture, and if you look carefully, you will find the clefts very prominent in the lesion, which makes it a clear-cut diagnosis of a phylloid tumor. If you have a bigger picture, look at the heterogeneity that you have. Look at the number of clefts that you have. So my dear, when you are looking at a plate, always look at not only the heterogeneity, but also look at the intralesional clefts. And these intralesional clefts are going to guide you whether it's a fibroadenoma or it's a phylloid tumor. And if you find it to be a phylloid tumor, obviously, as a surgeon, you will choose a wide local excision with 1 centimeter margin all around. Whereas in a fibroadenoma, you are just going to shell it out. We come to another
what is the difference? Sir?
Yeah.
What is the difference between cleft and a cystic space in a lesion?
Oh, it's a cystic space is a bigger space. A cleft is just a conduit. A cystic space is, when you look at it, there may be an internal area of. Is there somebody who is talking?
Shomesh sir, mute your mic.
Mr. Shomesh sir. Okay, he is possibly. Anyway, so what happens is that Dr. Somesh sir, can you just mute yourself? Thank you very much. Now, as I said, cystic lesions, I mean cyst within the fluid can be due to various reasons. Number one, I will show you the next picture, what a cyst and the solid thing can look like. That's a separate thing. Number two, there can be a cystic degeneration, but cleft is something like this. So it's like a small cleavage within a hill. And if you find these lesions, this is in one view, but in the other view, this will look like this. So this is a cleft, whereas a cystic lesion will either be a uniform cyst, which we'll show in the next, or it can be a cystic degeneration in malignancy, in which case the clefts are not there. It is a clear-cut space, defined, dilated, saccular space. Okay?
Sir, can you please show me the perilesional halo, sir?
Look at this. This is the perilesional halo. This whitish area is the perilesional halo. Look at this. This whitish area is the perilesional halo. Okay. Now look, go back. Look at this. This does not have a perilesional halo. This has a perilesional halo. Here the halo is interrupted by an acoustic shadow. So when you don't have a perilesional halo, then it is likely to be malignancy. But there will be some areas where it will be in between, and I will show you how to deal with those in between lesions. Okay?
Thank you, sir.
Now look at this. This is again an example. Now this is an unilocular cystic lesion, no doubt about it. And if you look, there is a perilesional halo. That's clear and distinct perilesional halo. It is a benign lesion. You don't need anything. If it's a large lesion, more than 2 centimeter lesion, you can put in a needle and aspirate it. But if it's a small lesion, you can tell the patient, go home, enjoy, come back after 6 weeks. Maybe we will do a repeat ultrasound to find what it is looking like. But look at this lesion. Okay, was there somebody asking me about a cystic degeneration? Now look at this. What do you see in this one? Anybody who can tell me? Anybody who can interpret this ultrasound?
So cystic lesion with a solid component.
Exactly. So you see the solid component here. This can be a papillary lesion, a papillary carcinoma. So there is a big difference. Now look, suddenly this halo is missing in this stone and an acoustic shadow is coming. So here it's an uniform halo. Here there is an acoustic shadow. So it is the first sign that this could be a malignant lesion. At the end of the talk, I am going to show you how it looks in an elastography. Now remember, when you have such acoustic shadow with a solid lesion, here you can ask the patient to go home. Here you need to do a guided core biopsy, because if you do a blind core biopsy, you are going to take the fluid out. And if you take the fluid out, it will be false negative. So under ultrasound guidance, you are going to put it down into here and take out the solid core and send it for biopsy. So you must be able to look at a lesion in the breast, which is a cystic lesion with solid component in one end, to be sure that you are not dealing or you are not missing a malignant lesion. Now we come to the malignant lesions of the breast. Now look, this is a lesion which you look carefully and you find that there is an architectural distortion here. Now this is another patient. Now this is a 20 times magnified view of a microcalcification in the breast. So most of you, if you are not trained to look at microcalcification, you will always miss it. Though we tell an architectural distortion and microcalcification are the hallmark of diagnosis, this is easy to understand, but this is tough to diagnose. And I'm going to show you some tips how to locate and understand that this is a microcalcification. Now look at this. When you put up a plate and you find there are distinct calcifications, like the ones you see here, the popcorns, the vascular, round, you just put up the plate, you find a distinct white calcification. This is a benign lesion. Something which your assistant, who is a non-medical assistant, can tell you, oh son, look, there is a calcification, is unlikely to be malignancy. But malignancy is one where the these are all magnified views. Now, if you look at this lesion, you find nothing. In a small plate, you won't be able to ascertain that there is a calcification. So the character of calcification is called a clustered microcalcification. What term did I utter? It is called clustered microcalcification. So what do we mean by cluster? We mean that in an area of 1 square centimeter, there has to be 5 different spots to call it a clustered microcalcification. So this is a clustered microcalcification. This is number 1. So what point did I tell? Clustered microcalcification. In an area of 1 square centimeter, there must be more than 5 dots. Come to this. Now look at these microcalcifications. So look at these microcalcifications. Look at these microcalcifications. They are heterogeneous in character. Every calcification is dissimilar to the other, and this is called a pleomorphic calcification. But if you look at the plate behind, these are not pleomorphic. They look like the same. It may be irregular, but they are not pleomorphic. But here it is pleomorphic and it is clustered. So the exact way of describing is a clustered microcalcification, that is more than 5 dots within an area of 5 centimeter, 1 square centimeter, and each of them must look different from the other to qualify as something called a pleomorphic calcification. So pleomorphism and clustering are the hallmark of malignant calcification.
Excuse me, sir.
Yeah.
Sir, how do you define pleomorphism here? It is regarding the shape or it is regarding the density, different density?
Shape.
Okay, sir.
Okay, so some will look like dot, the other will look like a tail, the other will look like something else. So all of them, they look differently. Clear?
Okay, sir. Thank you, sir.
Now we come to the next one. Now look here. Again, as you see, there is a clear-cut lesion here. Now I am unable to expand it, but if I can expand it, I would have shown, go very close, you are going to find small dots of microcalcification here in this particular area. And in this, in a computer, you need to magnify digitally hugely to understand that there are pleomorphic clustered microcalcification, or else you are going to just look and tell, oh, there is an architectural distortion. But what is the implication of having microcalcification here? The implication is it is extratumoral microcalcification. So if it is an extratumoral microcalcification, then it is likely not to be taken up for a breast conservation therapy. Now look carefully. Here you will find small pleomorphism. This is a patient with multicentric lesion, and therefore, again, breast conservation is not feasible. But as I said, you need to magnify it 10, 20 times in the computer to look at this microcalcification, or else you are going to excise this and the patient is going to come back with a recurrence here, or the margin is going to come out with positive if you're not looking at this clustered microcalcification. Now look, I have magnified it. Now can you see the microcalcification here? And can you see the microcalcification here? Can anybody put me an yes or no?
Yes, sir.
So you understand, once we magnify,
Yes, sir.
these microcalcifications become obvious. This microcalcifications becomes obvious, but in a small plate, you are unlikely to miss it. So therefore, the magnification of the plate needs to be done in certain circumstances to understand that it's a microcalcification. This is the same patient. This was done in another diagnostic center where it came out to be a unifocal lesion. And when we did a repeat one, this is an overexposed film, and therefore the microcalcification went missing. We were talking about density of the lesion. Now look at this. This is, all of you know, this is an inflammatory carcinoma. Now look what it does. You look here, there is a thickening of the dermis, the whole dermis. Now look at this. This is clear, but here you find that here it is completely dermal thickening, and the nipple is drawn inside. It touches the prepectoral muscles, and this is how the density increases. There is dermal thickening, and the nipple is indrawn and can be visible even in a mammographic plate.
So
Excuse
Yeah.
me.
Yeah.
So, can you tell us how to identify mediolateral oblique and craniocaudal oblique?
Oh, it's always written. It's always written. Now look at this. MLO. MLO. It's always written in the plate. Okay. Now this, I have taken out the other part, but it is always written whether it's a craniocaudal view or it's a mediolateral oblique view or a mediolateral view. So you don't need to put your brain. When you are given the plate, you look at the plate and try to understand whether it's a craniocaudal or it's a mediolateral or a mediolateral oblique view. Okay?
Okay, thank you, sir.
Now look at this. We have discussed, but once again, just a minute. প্রণবদা একটা মিটিং এ আছি, হয়ে গেলে করছি। Okay. Now, as I was telling that in this particular lesion, you can see the anteroposterior diameter and you can see the acoustic shadow. Now, if I superimpose this, this is an architectural distortion and the anteroposterior diameter is longer than the transverse diameter and therefore this is a distinctly malignant lesion. Now look at this. Now these are microlobulation. This is the lesion and you find the microlobulation that is happening towards the end of a duct, which can be a sort of early indication that this could be malignancy. Now very importantly, look at this. Now you find an area of hyperechogenicity here. Now as you change it in the real time, you start getting the acoustic shadow. Now this is because of the calcification and this shadow is because of the acoustic shadow that is happening because of the calcification. So you understand that the myth that microcalcification cannot be seen is wrong. If you look carefully, very carefully, you will be able to find that this hyperechogenicity is a microcalcification and turn around, you get the posterior acoustic shadow on the lesion, which distinctly tells that this is a malignant lesion. Now this
So
is
in
another question.
malignancy,
Yeah.
sir, in malignancy, the posterior acoustic shadowing is because of calcifications. We can think like that, sir.
Yeah, you can always think like that. Okay.
Thank you, sir.
Now this is another patient. Now this is a benign calcification here. There's a calcification, but this is benign. Okay. So again, if you look carefully in ultrasound, calcifications can be picked up. The problem is most of the ultrasound is done in such a hurried way, people tend to miss the microcalcification in them. Now coming to the axillary nodal evaluation, which is the third part. Now this is the anatomy of axilla, which I want you to understand very carefully. Now this is the outer layer, which is the capsule, and this is the lymph node, and this is the subcortical space. This is how the afferent channels enter, and this is how the efferent channel enters, and there is a perihilar fat. Now what happens is that when you have obliteration of the subcortical space, etc., and how it happens. Now look carefully. The malignant cells enters to the afferent cell. So once they start entering through these cells, they come into the subcortical space. And once they come into the subcortical space obliterates. So this is how it will obliterate. Now the second step is it is going to go to the medulla and try to come out. And once they try to come out, they get congested at the outlet. And therefore what happens is that there is effacement of the hilar plate. And once the outlet is also blocked, the inlet is also blocked, the whole thing changes into a globular shape. And the transverse diameter is significantly more than 7 millimeter. So do you understand what happens? This is the sequence which you must remember. So 1, the subcortical space is obliterated. B, it is completely filled with malignant cells. C, the hilar plate got effaced. And D, the whole thing changes into globular shape. Now look at this. Now look at this on this side. Now this is a distinct one. Now this is the hilum, which is intact, and it's a fat one, which is a globular, it's a reniform one. This is a malignant, this is a benign lesion. But look at this, this has turned into a globular lesion. And this globular lesion is due to a metastatic node in the axilla. So always keep in mind, when you are looking at the node, try to see whether you are getting the central halo, which is because of the hilar fat. And today I am just giving a brief introduction. I am not going to discuss on this. This is an absolutely advanced level. today we can even place in a marker, which is an iodine seed, which can be placed into the axillary node and keep it, and then undertake in neoadjuvant therapy. The whole thing shrinks. Then you can identify the iodine emitting lymph node and take it out later on as a post neoadjuvant therapy sentinel lymph node biopsy. But this is quite advanced. I just gave you a shot of how things are changing. Coming to the next one is called impalpable lesions of the breast. Of course, it goes with the screening and the way it evolved in the Western world. Though there are controversies whether screening is good or screening doesn't help, India, and there are evidences both in favor and against. India cannot choose to have a screening program because it costs 25,000 pounds, and Indians usually have a younger breast cancer, which is unlikely to be helpful in terms of mammography based products. But once in a while you are going to get lesions like this. Now again, look at this. This is a 7 millimeter lesion that you see here. So this is an impalpable lesion, 7 millimeter lesion in a 39 years female, which is irregular, which is suspicious of malignancy. So what we do in them is we place in a guide wire inside, a guide wire which looks like this, and then we do a surgery under the guidance of the guide wire. We take it out and subject it to a specimen mammogram. Now what we do, now this is a very early slide. I keep it because most of you will be able to understand. This was when the guide wires not available in India. We started with hypodermic needle. Now today we have guide wires. So once we do a guide wire, we take it out under the guidance of the guide wire, and say this is the specimen out with the guide wire or the hypodermic needle in situ, and then we are going to place it for specimen mammogram to see whether the index zone has been taken out or not, or an ultrasound that you see on the other side. And this is our innovation. You forget about that, but most of the circumstances, a specimen mammogram is going to show you the index zone has been taken out or not. Today, the glimpses of what is happening in the Institute of Oncology in Italy is something called a ROLE, which is called radio immunoguided localization of clinically occurred lesion. What is being done is that somebody injects into the tumor a radio emitting substance. So once it goes into the tumor, unlike in sentinel lymph node, where you do not inject into the tumor, you inject it peritumorally. Here you inject it into the tumor. So once you inject into the tumor, the whole thing starts emitting, but it is not going to come out and go anywhere. Now you take the patient to the operating room, under guidance, localize where the tumor is and excise it and go for a specimen mammogram to see whether the same thing is taken out or not. And this is the guideline for impalpable lesion. If it's a distinctly R1, R2 lesion, you just observe. If it is an R3, R4, or R5, means BIRAT 3, 4, 5 lesion, and if it's a clear-cut, predominantly microcalcification, then mammographic guided excision. If it is an only architectural distortion, ultrasound guided excision is done. Now this is another case capsule. Now look at this. This is a clear-cut Paget's disease of a patient who has got an excoriation of the nipple. And we did an ultrasound. We did a mammogram and an ultrasound as well. It revealed nothing. Then we did something called an MR. Now look in the MR, we get a non-mass enhancement here. Now this suggested that this could be a malignant microcalcification. We did a surgery and it came out to be a DCIS underneath the nipple areola complex. So there comes the role of the fourth tool, which is called a problem solving tool, also known as the MRI of the brain. Now, MRI of the brain is quite good in the sense that the overall sensitivity is between 85 to 100%. In IDC, the sensitivity is almost 100%. The specificity, however, is different between 37 to 100%. It's because at times it overdiagnoses a benign lesion as a malignant lesion. Now, let us see what is the role of MRI in present day. Number one, it is being used in patients with high risk familial or hereditary breast cancer. When you start the screening in the 20s, you cannot use mammogram so regularly, so you are going to use MRI in them. Number two, when it's a bilateral 3-fold lesion, you don't know what to do, you can use it at the MRI. If you have done a breast conservation surgery, there is something suspicion in the cavity, you can do an MRI. You have done an NACT and you want to be sure whether the lesion has resolved completely, MRI. And finally, if you have put in a prosthesis and whether there is a recurrence underneath the prosthesis, it is MRI. So these are the indications of doing MRI in today's world in breast evaluation. Now this is again, once again, the criteria is fixed. It's the mass, architectural distortion, invasiveness, mark the term enhancement, which is rim or non-mass. So I'm going to tell you what is a rim and a non-mass enhancement. Now look at this. This is a clear-cut lesion where there is a homogeneous enhancement and it's a type 1 curve. I will tell you what is a type 1 curve. So this is distinctly benign lesion, no confusions. Now come to this. The confusion starts. Now there is no mass, but there is non-mass enhancement. There are here and there are multiple enhancements that are taking up. And though there is no distinct mass and they are showing a type 3 curve. I will tell you again what are these curves. So there is no mass, but there is non-mass enhancement, which is equal to some sort closely to microcalcification. This is DCIS. Come to this. Again, this is an enhancement that you see. And this is again an enhancement that you see, but this is a non-mass rim enhancement. This is a classical sign of a malignancy with a non-mass rim enhancement, which is a sign of DCIS. So you understand there has to be a heterogeneous enhancement or a non-mass enhancement like the ones you hear. This is a non-mass enhancement and this is a rim enhancement. So if you find this sort of enhancements in MRI, you start thinking that these are malignant enhancements. And if you add gadolinium, what happens is that these malignant lesions are likely to be more porous because they are more vascular. So they give the enhancement better. So therefore, a gadolinium contrast often helps in accentuating the lesion in the breast. Now, I was talking about the curve. Now, what happens? In a benign lesion, what happens is that they take up the contrast slowly, they slowly go into a sort of plateau. And this is called a type 1 enhancement. This is always benign. So then comes the type 2 curve. In the type 2 curve, it comes, but the plateau is attained. So once you get a plateau again, the possibility is it is mostly a benign lesion. But if you find a lesion like this, where there is a rapid enhancement, you give and immediately it is enhanced. And there's an early washout. This is a malignant lesion. So for your practical purpose, remember type 1, type 2 are benign and type 3 is malignant. So if you have an early peak enhancement and early washout, that is a sign of a malignant lesion. So remember, an architectural distortion, a rim enhancement, or a non-mass enhancement, or a heterogeneous enhancement with a type 3 curve is indicative of a malignant lesion. So comparing between MR and mammogram, in MRI, you have some distinct advantages. Number one, the lesion categorization, the focality, centricity, nodal status are always better seen in MRI, but it is costly and it is not a tool which you can use in everyone. You go for a post-excisional margin. I told you, you have done a base conservation, you have doubt, MRI scores over mammogram. If you have done a post-radiation, now there is a recurrence, you are unsure. Again, you do an MRI, the enhancement speaks. The early enhancement, early washout speaks that this is a malignant recurrence, whereas mammogram is not going to be able to differentiate it. Now, to try to differentiate between an inflammatory changes, you have given radiation, the whole thing is swollen up. You don't know whether it's a post-surgical enhancement or radiation enhancement. But if you use MRI with wisdom, you will be able to differentiate between the two. As a problem-solving tool in arteriation, contrast MRI, as I said, is better. Whereas in mammogram, as I said, you need to magnify the whole thing. Look very carefully if you're missing a microcalcification knot. For detecting occult lesion, as I shown you the picture of that patient with Paget's, where there was a lesion which was very small, less than 5 millimeter, was picked up in MRI, but was missed in a mammogram. For mass screening, MRI is not helpful because it is costly and you cannot apply it to every nook and corner of a country. Mammogram and ultrasound scores. In high-risk screening, that means when you are using in a familial breast cancer, of course, you are not going to give the radiation hazards to a patient, and in them, MRI is helpful. And finally, a routine preoperative assessment tool, again, the standard of care is mammogram plus ultrasound and not MRI. In a small subset of centers, people use MRI before breast conservation, but that's not the standard of care. The always use a mammogram and an ultrasound. Coming to the last segment, which is called the elastography. Now, guys, you need to understand about this tool. This is a tool which is evolving. Now, why this tool is evolving is this is a non-invasive evaluation of the stiffness of a lesion. Now, what happens is that now, if this is a water-filled balloon and you push your finger, it displaces the water like the ones that you do in an elastogram. So it displaces the water. Once you release the pressure, the whole thing comes back. And this is the normal character of a benign lesion. You push it, it dips, and it releases, it comes back. So deformability, easy deformability is a character of a benign lesion, and rigidity is the character of a malignant lesion. Though, of course, there can be a combination of two in certain lesions, but as a rule, if you find a hard lesion, then it is likely to be a malignant lesion. Now let us see what it does. So this is what I was telling. A malignant lesion is likely to be a hard lesion. So it is not a matter of wisdom to use elastography in every patient. In patients who are having BIDATS 3 or 4A lesions, that means it is between 1% to 10% possibility it can be a malignant lesion. 90% possibility it's a benign lesion. You need to be more careful about that. And in those cases, you can use elastogram. And in elastogram, there are two different techniques. You forget about the strain elastography and shear elastography. Just remember one thing, that we can add a color code to the lesion. I'm going to show you the color code. And you can add a color code to the lesion, and you can make look, say a red is a sign of rigidity and blue is a sign of elasticity. And if a lesion is red, that means it's malignant. The second is in a shear wave ultrasonography, you can actually note in kilopascals per meter or second. So if you find that the kilopascal of a lesion is very high, say 200, that means it's a very rigid lesion. If it is only 90, that means it's a soft, elastic, pliable lesion. It's just like a small squeezy ball, and therefore in them it is likely to be a benign lesion. Now look at malignancy. Now this is a lesion where you find which is a malignant lesion. What happens is surrounding it, there will be a desmoplastic reaction. And this desmoplastic reaction will not allow the lesion to be compressible. And therefore in them, the kilopascal will be high and the lesion is likely to be red. Though, of course, it can be false positive in say, traumatic fat necrosis, in colloid cancer, in DCIS, it can be negative. But by and large, lesions which are red, which has got high kilopascals, are likely to be malignant lesions. Now look carefully. Now this is a lesion that you see on this side, and this lesion is, you are uncertain. It is heterogeneous. It appears to be taller than wide. It has a halo around it. So you are uncertain. So it's a BIDAT 3-4 lesion. So you subject it to an elastogram. Suddenly it brilliantly gets red. And if you look carefully, the kilopascal is written here. And suddenly you get a kilopascal here from 0 to it is going up to almost 200. So higher the kilopascal, the more reddish the lesion is. And therefore, looking at this, you'd be able to tell, now look, this is a BIRAD 3 lesion in ultrasound, but I did an elastogram on this and I could tell it is red with 200 kilopascal. So it is likely to be a malignant lesion. So I must plan my treatment accordingly. Now, again, this is another lesion. Look carefully. This is a lesion which apparently seems to be benign. You have added it on elastogram. It turns blue. That means it is a spongy lesion. It goes down and the kilopascal is, as you see here, the kilopascal is somewhere between 21 to 11. So likely that this is a compressible lesion, and such a compressible lesion can only be a benign lesion. And therefore, you can be very sure with the addition of ultrasound elastogram that this is a benign lesion. You have the classifications.
What are the indications of elastogram, sir?
As I said, it is for BIRADS 3 and BIRADS 4 lesion. If it is clear-cut malignant or if it is clear-cut benign, you can only add it for a trial reasons. But routinely, you should not be adding an elastogram or then. Clear?
Yes, sir. Thank you.
Okay. Now, this is the classification. This is called Tsukuba classification. But again, I would suggest that you just remember, again, based on the basic principle is like this. Now, score 1 is a completely deformable lesion. It goes down and it comes back, bounces back. Score 2 is majority portion is deformable, minor area is stiffness. Now, look at this. Majority area is deformable, minor area is stiff. Then there is a central stiffness, the periphery is deformable. Again, it has now started to go into a malignant lesion. It is completely stiff. It is a malignant lesion. It is completely stiff with the surrounding area showing non-deformable lesion. That means there is an intense, as I said, desmoplastic reaction around it, and this can be nothing but a malignant lesion. So the keywords is the role of elastography is in BIRADS 3, BIRADS 4A and 4B lesions, and not routinely in all lesions. Role is more in complex cystic lesion. You recollect the lesion that I was stating with one end which was showing a solid lesion in a complex cyst. And if you add an elastogram to that, what happens is suddenly you see that area is stained red, and that means that is a malignant lesion. You add the elasticity in kPa, you suddenly find it's a high kPa. That means it's 200 kPa, so it is a malignant lesion. So note the color coding superimposed on the grayscale and the elasticity count, and you would be able to tell whether this is a benign or it is a malignant lesion. So I come to the end where I tell that ultrasound and mammography remains the gold standard. Elastogram is added in borderline lesions 3, 4A, at best to 4F while performing ultrasound. Ultrasound and mammogram is used for guided procedure most commonly. That means if you want to do a core biopsy under guidance, you choose an ultrasound or a mammogram. MRI is a problem-solving tool and finds some use in assessing the focality and centricity of the lesion. So thank you very much. Any questions, I'd be happy to answer.
Sir, which one should be the first choice amongst USG and mammography?
So as I said, if the age of the patient is less than 35, you go only for ultrasound. If the age of the patient, and of course with ultrasound, you can add an elastogram. If you are doing at the age above 35, it's an ultrasound plus a mammogram. As you grow old, the fat replaces the breast tissue, mammogram becomes the choice, and ultrasound becomes the complement to it. Clear?
Sir, is it 35 or 45, sir?
35 or 40, there are some centers we use 35, some centers which we use 40. I personally use 40, but the Radiological Association tells it to be 35. So I have given the BC grade where they tell the Radiological Society of India, which tells 35.
Okay, sir. Thank you, sir.
Sir, what exactly is a specimen mammography?
The specimen mammogram is you excise the lesion. Okay, you take this lesion out, the lesion, you immediately ask your resident to run into the radiology department, and they would immediately go for a mammogram of the specimen. And in the mammogram of the specimen, you will find that the microcalcification or the architectural distortion is taken out, because you are actually going into a 7 millimeter lesion. And if you have taken out normal breast tissue, then you won't be able to find the lesion in the postoperative specimen mammogram. So you have to compare what you saw before and what you saw after the surgery is being done. So the specimen that is evaluated after the ultrasound is being done is known as postoperative or specimen mammogram.
Thank you, sir.
Any other questions? So I gather most of you are surgeons, and if you are surgeons, what important things that you must know is the BIRAD score, ultrasound, findings, and you must be able to emphasize on the examiner what is a pleomorphic clustered microcalcification, what are the features in ultrasound of a metastatic node. You must be able to tell what are the features in ultrasound of a primary malignant lesion, what is the role of MRI, and what is elastogram. So I think if you have this as a knowledge base, it is fantastic. You need not bother about anything else. Okay, any question? So guys, if you have any other question, you can put it to the group, and they are going to forward it to me. And if I know the answer, I'll be able to help you out with the answer. But I hope you were able to understand the basics of breast radiology. Okay.
Sir, is the topic occult breast lesions important in practical examinations? I mean, I did not understand that part very much.
Okay. So occult breast lesion is like this, a 39 years female. Now in the West, what happens is that, after the age of 49 years in UK, the NHS will go to every female's house, take them out and do a mammogram at 3-yearly interval. In certain countries in the Scandinavia, they would do it at 2-yearly interval. And once they pick up a lesion in the breast in ultrasound or in mammogram, they would immediately subject it to a biopsy. In our country, we are unable to have a mammography-based screening program due to certain reasons. These are the reasons. So many of our patients come. You will find a patient coming to your clinic having a small lesion, which is a BIRAD 4B. But if you try to palpate, you are unable to make the palpation and find it there. So either you have to do a core biopsy, guided core biopsy, which not many people can do, because it's a 7 millimeter lesion. You put in a core biopsy, you might get a false negativity. FNA should not be done. So in them, you place a guide wire inside the lesion, like this is being done. We used to take the patient to the theater in the morning. We didn't have a hypodermic needle in those days. We didn't have the guide wire in those days. So one of my residents used to put in a hypodermic needle in the ultrasound department, then transport the patient to the operating room. In the operating room, guided by the guide wire, we would excise the lesion like the schematically that you see. And then this is the lesion, which is just a 1 centimeter lesion, which is taken out with the guide wire or the hypodermic needle in situ. And then we subject it to on a specimen mammogram to see whether that area of microcalcification has been removed or not. If you find that it is not removed, you go back and once again re-excise. Clear?
Yes, sir.
This is a theory question,
Sir,
not really practical question.
Sir, I am a practicing surgeon. and doing sonography myself. I just wanted to ask you, in a case of a breast lump, when we are doing sonography, how will we differentiate lesion to be a inflammatory or it to be a solid, benign and malignant mass?
Sir, that is a nice question. I mean, inflammatory lesions will not have the character that we spoke of in malignancy. In malignancy, the lesion will have, as I said, characteristically these features. So look at this, sir. Now you are having a lesion whose anteroposterior diameter is longer than the transverse diameter. You will have this architectural distortion. You will have posterior acoustic shadow, and there is no halo around. And if you add a Doppler to this, you will be able to see that there is an arborization of vessel within the lesion. Benign lesion is completely different, but an inflammatory lesion, you will be able to see hyperechogenicity within the lesion. That means within the lesion, let me see whether I have a picture or not here. So within the lesion, you find a hyperechogenicity. If you find that, that means it's a collection of pus. You can actually put in a needle inside and aspirate to see whether it is a pus or not. But there are certain circumstances, particularly in idiopathic granulomatous mastitis and inflammatory carcinoma, where the lump is completely ill-defined. It may be very difficult to differentiate between the two, but a distinct inflammation with an abscess versus a carcinoma can always be easily ascertainable. Let me see whether I have the picture here. No, I don't have the picture here. Or else I would have been able to show you how an hyperechogenicity within a lesion can be there. Any other questions? So if there are no questions, you can always write to us and I'll be happy to answer those questions, whatever comes up. Oh no, see, I got this picture. Now look at this. This is a lesion which has got a central area, which is an abscess. This is somewhere where you find the difference. And you will never find such a lesion when you are doing an ultrasound in a malignant lesion. Okay.
Yes, sir.
Thank you. Thank you, Dr. Bora. So thank you again, once again.